Hello guys, good evening, welcome to NEET PG Live Daily. Guys, you can see today I'm in jacket, and I officially declare that winter has come. So you guys should be little prepared for this winter and all, because I am from Jodhpur and you can understand this hottest state, you can say, in which I have to wear a jacket. It means that cold waves are running throughout the country, so you take care, be safe. This is the time most of the guy falls sick and all that, and you can't afford to be sick because you are preparing for your PG entrance and all, so you can't waste days and all that in your illness. And so please avoid exposure to extreme cold and all that, and take proper precautions. So guys, in this series of endocrinology drugs, we last time discussed pituitary hormones and related drugs, the part 1, and today is the 6th lecture of this series, and I will be concluding. This is the concluding part of this pituitary related drugs, and we'll hope, and today we'll try to finish it up, and then you will have no issues related to pituitary. And you can send, if you have any query, you can catch me on your Unacademy learning app. If you are following me, you can send me direct message. So if you have any issues, because it's difficult for me to keep watch on your chat box while I'm delivering lecture on this YTube NEET PG Live Daily. So this is little difficult for me. I cannot keep up with this both the activity at the same time. So whenever you feel like, you can always send me and messages through Unacademy learning app, because there also I take classes. And guys, thanks for all your support and whatever comments you give, positive comments, I really like them. Thanks for all that. I see them later, and or my wife keep watch on that. So thank you for all those positive comments. That makes me little give me inspiration, in fact impetus to do better and come up with better informative content for the learners. Guys, those who are have never attended my class, let me introduce myself, that I am Dr. Pramod Sharma. I have done my MD and DM from both from PGI Chandigarh, and I have received Rastriya Gaurav Award in year 2017, and I have been made brand ambassador of Bentham Science Publishers, because and it's a very globally renowned acknowledged publisher which publishes medical books and medical journals, etc. And I'm also worked as a subject expert committee member on behalf of Ministry of Health and Family Welfare to guide them on national policies and all that. Guys, I keep telling you that this Telegram channel or Telegram app is of immense use for you guys, because this Telegram app is just like this you can see WhatsApp messenger app kind of thing. There number of participants may be more on this Telegram channel. That is why we have selected this Telegram channel as a means of transmitting information for our learners. So being on this channel is not sufficient. You have to join this group so that you can get all the notification related to classes, timetable, etc. And many educators share their link of their presentation live sessions on this YouTube channel. So you can directly clicking that link, you can directly reach to the NEET PG Live Daily channel and can watch that lesson, and without searching for that. So but this is here on this group, you cannot send message, you can only receive messages. So that is good enough for you, because having timetable or schedule of the classes well before in time would definitely help you adjust your daily timetable so that you have time to watch these lessons. The Unacademy has a subscription-based service also for these NEET PG aspirants, that is in the form of Plus, and it has several Plus features. In fact, I would rather say that that is why it is Plus, because you have additional features which no platform offers. And if you see what are these features, that the live classes which happens on this platform is similar to what I am taking right now, but the advantage there is the number of learners are less on this platform because it is a paid platform, and it can be very well expected that the paid service, always the subscribers are always less. So you have a lot of opportunity to interact with the educator. In fact, these classes are more interactive because there is quite often interaction between the educator and the learner. So it is a healthy thing. Real-time interaction between a learner and the educator is a must, in fact, to improve the outcome or efficiency of any learning process, in fact. And other than that, we have a facility of live post, leaderboard. You can use these facilities to give your feedback regarding the content or the anything else. So all those creative feedbacks are taken very seriously, and Unacademy does everything to incorporate those really good changes which you have suggested, or any customization in the class or the timing or anything, whatever you feel like can always demand from Unacademy. And the leaderboard is the facility also which provides you sort of confidence, or in fact they keep you informed where exactly you are standing in your group, and that gives you an idea about your own performance. And you can very well anticipate by seeing the leaderboard that you are lagging behind, or you are walking with the pace of the group, or you need to work on certain areas where or you really need to work hard to get at par with your colleagues. So this leaderboard is also helpful for us to focus our attention on the group, where exactly group is actually lagging, or any particular the learner is requiring attention, or individualized focus on some areas. And this advantage of this platform is that the number of students are less, so educator can give personalized attention to each and every subscriber if possible. Many times it is possible, and so this is the advantage. And as far as the study material is available for these subscribers, there is no dearth of study material available on this site. You have lot many test series there, their analysis, as well as the not only that analysis, and as well as the quizzes, etc. So you can try doing all these things. That would definitely make you more knowledgeable. It will dispel all your confusions regarding your doubts, the areas where you most often commit mistakes and all that. So that will be definitely abbreviated. So keep learning from this test series and all that. That is always in your benefit. And as per the protocol, this is the protocol imposed by Unacademy on the educators, that whenever you take class on this Plus, the student should have all the opportunity to ask his doubts and or ask their doubts or any confusion, etc. Though they can ask during the live classes, but even if they cannot, then after every 3 lessons, the educator is supposed to take a live doubt clearing session, where in all these any query which may arise later on from student side, they can always clarify their doubts during this session. So this is actually this subscription based service, this premier service is made keeping in mind the requirement of a PG aspirant, what exactly a PG aspirant wants, because Unacademy knows this, no other than Unacademy understand this better, because they are into this field for quite some time, and is number one learning platform for all these students, so they understand what ingredients are actually need to be incorporated in this sort of subscription based program or platform. So you will get all what you need. So this is all all services under one roof. So this is one subscription with unlimited access, and this caters to all your need, and you don't have to go here and there, and this program is one-stop solution for all your needs. These are the subscription rate for the plus this NEET PG subscription. Those who want to buy this subscription, the subscription is available for the different duration, right from 1 month to 24 month, and the rates are vary according to the duration of the subscription. And but those who actually buy subscription for 6 months or more get the they become eligible for no cost EMI, without any increase in the cost. They can pay the same amount in parts. And but if you are applying to subscription through some educators referral code, using some educators referral code, like you are using my code, if you are influenced by my way of teaching and style, everything, and you feel like that you should be there on this platform, so you can use my code, and this is the space given there. For example, this is the the subscription rate after the 10% discount. So here, but you have to apply my code like Dr. Pramod, and you will get 10% discount. Though the subscription is available for different durations, but we often suggest these 2 durations, and that is actually very much logical as well, because those who have completed already their MBBS and are actually have appeared or appearing for the first time, they need to take this 12-month subscription, because 12-month time is required to get attached or remain associated with a learning platform to fully realize its potential. Because being there with the some learning platform for a month or so would never solve your problem. You will keep hopping from one place to another, but ultimately you will get nothing. So stick to this particular platform for a year, because the course or the syllabus is really voluminous, that takes time to be finished, and you will better that how many subjects are there. So you will be taught by or expert from all the medical specialty to cover up the entire syllabus, and for that you need time and to understand. And not only that, these educators are very learned, and they are well experienced. They know what exactly you need, and accordingly they keep posting their specialized program or specialized courses on this particular platform. So more during these 12 months you will be attending many such programs, and that makes you a better learner, and definitely you will do better than or you will be a better learner, in the sense that you will be score which I believe would be better than what you can score right now. But there should be you have to add the ingredient of your hard work as well, and that is the key to your success, or the crux of the your success story. So those guys can take the subscription for 12 months. 24 months subscription is good enough for in fact best for those who are in the final year MBBS, and from today they have started they are in the competitive mode, so they can go for this kind of subscription, because the cheapest which is available right now, and they not only gain benefit in terms of scoring better in their university exam once they attend this subscription based service, but it may be possible that the first time when they appear for their PG entrance and they have really worked hard, that the result may be really surprising for them. So this is the reason why we recommend these two duration more often, because it makes sense to buy a subscription for at least 12 months, those who are post MBBS student and these who are UG student. See, after applying the code like mine, you can get 10% discount for 4 months. It was 40,000. Now it has become 36,000. This 12 months became 24,750. So these are all, the benefit you can get just by, applying this referral code of the educator. And don't forget to apply this, because this will avail you 10% instant discount. And there are different ways of paying, different digital modes through which you can make payment, and these payment can be through cards or other UPI method, etc. So whatever digital method you prefer, you can always go through that. So that was all about the Unacademy subscription, its advantages and specialized feature, in fact, which can help you realizing your goals and all that. And definitely, if once you get attached to this program or this platform, you will feel the difference. Not immediately, you will feel the difference within a month or so, that yes, I should have been here before, in fact. So that kind of feeling you will have. But for now, it's time to come to the topic proper. So as we run through the different slides, we will unravel the story behind these all pituitary hormones and related drugs, the part 1 of which has already been covered. So this is the second part. Let us start with this GnRH receptor antagonist. Last time we had a whole discussion on growth hormone and etc. And GnRH agonist we talked about. We had gonadotropin, we had GnRH receptor agonist like leprolide, goserelin. Leprolide is also known as leprorelin, and hysterelin, nafarelin, triptorelin, all these drugs, buserelin, we have discussed their clinical utility and etc. So today I am going to talk about GnRH receptor antagonists at the outset. We have, in fact, 4 GnRH receptor. This is gonadotropin releasing hormone. You should not forget this, because this is released from from hypothalamus, which stimulate release of LH and FSH from the pituitary, and this acts on the target organs like gonads and can produce estrogen, progesterone, testosterone, etc. So these GnRH receptor antagonists, first of all, you should know where these receptors are present. These are present on pituitary gonadotropes. And these are all G protein coupled receptors. And that GnRH, which is released from the hypothalamus, its release is pulsatile. It is released in pulses, not continuous release. So these receptors actually respond to pulsatile release of GnRH and do not lose their sensitivity to gonadotropin releasing hormone. What happens if there is continuously they are exposed to GnRH or their analogs? What happens? These receptors undergo down regulation, and the effect may be reduced, may be dampened, and ultimately it will be inhibited. So GnRH analogs were, in fact, they are called GnRH analog, but they were actually antagonist for this GnRH action. They inhibit GnRH action. They do inhibit gonadotropin production by pituitary, because initially they act as agonist, but later on, because of the continuous or consistent stimulation of the these receptors, led to the inhibition of GnRH effect on the pituitary. But these agents are direct receptor antagonist. So we have 4 antagonists: GnRH, cetrorelix, abarelix, and degarelix or dejarelix. These are all synthetic. Synthetic means they are not chemical. They are not chemically synthesized compound, or they are not small molecules. They are biological compounds. Like GnRH decapeptide, certain changes have been made, and they have developed this kind of activity, antagonistic activity. They have high affinity. They are competitive antagonists of these GnRH receptors. I have already discussed. These are GPCR present on the gonadotropes in the pituitary. By blocking these receptors, they inhibit the action of the GnRH that is released pulsatile in the pulsatile fashion. So they inhibit action on these receptors and inhibit secretion of both gonadotropin, FSH, and LH in a dose-dependent manner. In fact, yes, why dose-dependent manner? Because this is competitive antagonism. So the competitive antagonism, you should know that it depends upon the relative concentration of an agonist or antagonist. So whichever will be in the higher concentration, the more likely the receptor will exhibit that kind of effect. So the dose dependent manner means if you keep increasing the doses so that it is much in higher concentration than its pure agonist or full agonist like GnRH, then the antagonistic effect will be more prominent. That is why the action is dose dependent. Especially these GnRH and cetrorelix have been approved for this COS. COS is controlled ovarian stimulation. This controlled ovarian stimulation is the cornerstone for this assisted reproduction technology, which we call it as in vitro fertilization. Actually, it is they are used to prevent the endogenous LH surge. LH surge, that is endogenous, endogenous LH surge. Premature endogenous LH surge, because in this protocol, this IVF cycle, we control everything through drugs. Everything is under our control. We do not allow things as per this physiologically what happens, and this actually prevent LH surge, and this offers advantages over GnRH analogs which we are using. Yes, we talked about in the last class that they can also be used for the same purpose, but this antagonists have advantages over GnRH agonist. For example, this antagonist have they have inhibitory effect or immediate inhibitory effect. They have immediate inhibitory effect because they are receptor antagonists. They do not need anything. They just bind to the receptor and inhibit the action of the GnRH. Unlike GnRH analog, which were actually there because as they are analog, they first stimulate the receptor for some days, 7 to 10 days. After that, this downregulation of regulation of receptor occurs and the kind of inhibition occurs. But these drug has immediate effect. They don't need this because they have no action at all on the receptor. They just prevent the action of gonadotropin releasing hormone. So advantage is that their use can be delayed in this IVF cycle for 6 to 8 days later, because otherwise this GnRH analogs are being used from the preceding mid-luteal phase. Right from the mid-luteal phase it has to be started, but these can be started delayed in fact in the follicular phase. So they need a shorter course of treatment with these agents when you are managing IVF cycle and etc. Another advantage is it has less suppressive effect on the ovarian response, because whatever we are doing, that effect is this IVF cycle, it is to stimulate follicles etc. So every effect is on the ovary, so it has less suppressive effect on the ovarian response to gonadotropins. So what will happen, it will require less of gonadotropins and less duration is decreased, as well as the quantity that is required is also reduced. So this is a cost effective way of gonadotropins are costly, but there are, when an agent or certain group of drugs have advantages, it's not possible to have it is always a possibility they will have certain disadvantages also. For example, these antagonists, the moment they are stopped or you do not comply with the instruction, you do not take miss a dose, the effects are reversed quickly on discontinuation. The reason being but that is not the case in when we use GnRH analogs. So here the adherence to the treatment protocol is of paramount importance and is critical for the success of this kind of IVF cycle. You can see this is the native GnRH which is a TECA peptide, and the first three these amino acids are important for receptor binding and activation of the receptor, GnRH receptor, that are GPCR, G protein coupled receptors, and the last three are also important for receptor binding. That is if you keep certain changes have been made in that will in fact increase the affinity of these receptors for these agents for receptors. And sixth amino acid changes here are is related to their activity. I showed you the last time also regarding GnRH analogs, similar kind of diagram also. So here the D amino acid substitution is important. Here, for example, this is D amino phenylalanine, this carbonyl actually, D asparagine, D citrulline, D homoarginine, this ET is ethyl, so ET2 is diethyl, like this. So all these things are important. These changes have been made, so they are all peptides. They are not small molecules but synthetic, because we have made changes in that these. So this GnRH native molecules. So based on that, we could modulate or manipulate the activity of these analogs, and they are actually behaving as GnRH receptor antagonists instead of acting as GnRH analog. Another disadvantage is that they can cause more complete suppression of LH secretion. More complete suppression of LH secretions. So this may in fact impair the development of the successful development of the follicle, which is being development of follicle which is being stimulated by the use of recombinant FSH, or because FSH is important in follicle development, or purified FSH which is derived from urine. I will discuss all this thing, So this can happen because LH is also important in this follicular development and all that. So this more complete suppression of LH secretion may interfere with this. Right. So this actually produces a condition like hypogonadotropic hypogonadism. In that situation, we need LH and FSH both to successfully complete the IVF cycle. I will discuss that. I will show you how an IVF cycle is actually maintained with the exogenous administration of certain drugs and hormones, right? And it has been, the data has been has emerged from different scientific studies, and that indicates and points to little lower rate of efficacy. It means the rate of pregnancy rate are little lower with these antagonists in comparison to GnRH analog. That could be the reason why, because it is causing more complete suppression of LH secretion. That could be one of the reason probably. And so it has been observed, because the data are the basis for giving the such remarks and all that, concluding remark. The common adverse effect associated with these kind of drugs are nausea and headache. So cetrorelix and genurelix were approved for this controlled ovarian stimulation program, but dejarelix and ebarelix are approved for advanced prostatic carcinoma, because prostate is a genital organ which is under the control of has been androgens can have a trophic effect on prostate and all that. So in patient with advanced prostate carcinoma, use of these GnRH receptor antagonists, what they will do, they will reduce the concentration of LH and FSH by blocking the action of GnRH, and that will ultimately lead to decreased production of androgens. So this concentration of gonadotropins as well as androgens decreased more rapidly in comparison to the GnRH analog. The reason is same, because GnRH analog will first stimulate these receptors and will increase the secretion of LH and FSH, and that will ultimately lead to increase in testosterone. So what will happen? Initially there will be actually increased growth of the tumor. This may happen. Patient who have bone metastasis, they might experience increase in their bone pain, etc. And those who have metastasis in the vertebral bodies and all that, it might collapse because of the increase this activity of increased testosterone level and all that, and they might present with some neurological deficit, etc. And because of the initial rapid growth of this tumor and all that, stimulated by steep rise in the testosterone because of the GnRH analogs, so there may be urinary retention, etc. can occur. But that is called tumor flare syndrome. So just to avoid that kind of issue or problem, we had to add GnRH, and along with GnRH analogs, we had to have add androgen receptor antagonists also to cut down the chances of that tumor flare syndrome. But here we are using GnRH receptor antagonist. We are using not androgen receptor, GnRH receptor antagonist. So here there is no testosterone, plasma testosterone concentration increase, and as seen with GnRH agonist, and the concentration falls more rapidly, and there is no tumor flare response. This is the advantage with these GnRH antagonists, right? And the common side effects that are associated with these GnRH antagonists are injection site reaction, because they are to be given by parenteral route, and one of the agent that Deja-Relix can impair the liver function test, so this is important. And because they reduce the production of these gonadotropins and finally the gonadal hormones, so it produces a state similar to androgen deprivation and can present with similar feature like hot flashes, sweating, etc. And weight gain can also occur. So this was all about GnRH. We have already discussed how we can manipulate gonadotropin releasing hormone, that is hypothalamic hormone. Now we will be talking about gonadotropins. Gonadotropins means these hormones which are released under the influence of gonadotropin releasing hormone from the pituitary. So we have three gonadotropins: FSH, follicle stimulating hormone, luteinizing hormone, and human chorionic gonadotropin. Remember, these two are actually pituitary hormones. SCG is not a pituitary hormone, but it is a gonadotropin. It is released from the placenta. It is a placental hormone. So these gonadotropins are very important because they are released from the gonadotrops cells of the pituitary, anterior pituitary, under the influence of gonadotropin releasing hormone. And these gonadotropins have complementary role in the different reproductive process function, both in man and women. For example, let us see what exactly these gonadotropins, what kind of function they perform. In women, this FSH is important, very important. Its most important action is to stimulate ovarian follicle development. Whatever ovarian follicle development occurs, that occurs the influence of FSH. FSH is the primary hormone that stimulates this follicular development in the ovary. Not only that, this FSH has also another role to play, that it stimulates conversion of androgen to estrogen by the granulosa cells of the ovary. There are other cells in the ovary, also theca cells, which are important for production of androgen, and that is produced under the influence of LH, luteinizing hormone. So LH stimulates androgen production by the theca cells of the ovary. FSH stimulates conversion of androgen to estrogen by granulosa cells of the And usually, what is the role of this SCG? SCG is the hormone I said this is released from the placenta. Usually what happens during a menstrual cycle, when this ovulation occurs, and then for sometimes this estrogen and progesterone levels are maintained during the luteal phase under the influence of maternal LH. But within few days, this actually, as the concentration of estrogen and progesterone increases, this is not sufficient. Maternal LH is not sufficient to maintain luteal phase and all that. So in that case, HCG take over the role of maternal LH, and then it maintains the corpus luteum. This SCG maintains the corpus luteum because it is released from the syncytial trophoblast of the placenta, and corpus luteum is responsible for maintenance of pregnancy up to 8 weeks. Thereafter the placenta takes the entire role because it produces all the hormones in sufficient concentration to take care of the ongoing pregnancy. So this SCH takes the role of the LH because once it starts it gets start forming from the placenta, that it take the charge of the maternal LH and maintains the estrogen and progesterone levels during the pregnancy. HCG is very identical to LH in its structure as well, and functions are also similar, and they can be used interchangeably in many clinical indications. In men, these gonadotropins, because we know that these gonadotropins are important for both the sexes, they assist many reproductive processes. For example, this follicle stimulating hormone that was important for follicular development in females, ovarian follicular development, here this FSH is important in regulating spermatogenesis. It is the major gonadotropin that regulates spermatogenesis, and it ensures that the local androgen concentration is high where the sperms are being developed. So this is achieved by enhancing the production of androgen binding proteins by the under the influence of this FSH by the Sertoli cells. The Sertoli cells in human testis actually secrete this androgen binding protein, and that binds androgen, keeps the concentration of local concentration of androgen in the vicinity of developing sperms in much higher range. In addition to that, so LH, this FSH can also stimulate conversion of testosterone to estrogen by the Sertoli cells, because this estrogen is also important. Participation of estrogen along with testosterone is also important for proper spermatogenesis. This is essential as well. And LH is more important in stimulating testosterone synthesis in the Leydig cells. They are synthesized from testosterone released by the Leydig cells. So these various pharmaceutical formulation of this FSH, LH and SCG are available, and they are used in infertility, sorry. Used in fertility, for example, for ensuring the proper spermatogenesis in male and follicular development or induction of ovulation in females. However, the most important clinical use of these gonadotropins nowadays is for controlled ovarian stimulation. As I earlier said, also is the cornerstone of assisted reproduction technology that are called ART. Not antiretroviral therapy, assisted reproduction technology, which is typically known as in vitro fertilization. So in vitro fertilization is we develop ovum in women, and we do in vitro fertilize it and then transplant it again in the recipient. And so fertilization occurs in vitro. That is the major important thing in this in vitro fertilization technique. If you see structure wise, these gonadotropins, all three gonadotropins are glycoprotein hormones, glycoproteins, and they act through GPCR, that is G protein coupled receptors. They are actually heterodimeric. Heterodimeric means they have two types of subunit and different. So they have alpha subunit and beta subunit. All three hormones share an identical alpha subunit. So alpha subunit is same in all, but these beta subunits have difference, and that confers, the difference in beta subunit structure confers receptor specificity, Otherwise, why there is need for naming them differently? They would be all same if they have similar beta subunit also. So these hormones are in alpha units are identical. There are different little changes, means variation in beta subunit that confers receptor sensitivity, and LH and SCG, I told you earlier also that they can be used interchangeably because their structure is very identical, and this SCG also acts through the LH receptors. The only difference between the LH and SCG is that beta subunits of the HCG has more glycosylation, than the more glycosylated residues than the LH. This is the only difference. Otherwise, there is no change. And these agents are, both administered subcutaneously or intramuscularly, and to be given on daily basis, and half-life depend upon by which route you are actually giving these preparation, what are these preparations, and route of administration. Both are important and can vary from 10 to 40 hours. This is the difference in structural differences among all three gonadotropins, but you should understand only the LH and FSH are secreted by pituitary. The SCG is secreted by placenta, syncytial trophoblast cells of the placenta. You can see that alpha units are same. There are 2N glycosylation, FSH 2N glycosylation, 1N linked glycosylation in beta subunits of LH, but here there are 2N glycosylation and 4O linked glycosylation. This is the difference. This is the more glycosylated residues than the LH, but they can be used interchangeably and act on mainly only on LH receptors. It does not cross react with any other receptor. So we are talking about gonadotropins. We have different type of gonadotropins. For example, initially we had menotropins. These menotropins are nothing but mixture of LH and FSH, and they are also known as human menopausal gonadotropin. Human menopausal gonadotropins. They are actually obtained from the urine of the post-menopausal women, and that they are extracted in the purified extract of FSH and LH. But these initial preparations were highly contaminated with other proteins, and the biologically active proteins was only less than 5%. Active proteins FSH and LH were less than 5%, and the bioactivity of this FSH and LH in the older preparation, if you go by the ratio of the activity of FSH versus LH in these earlier preparations, it was 1:1, so that is fine. But as the purity increased of these extract, with the advancement in the technology and all that, the purity increased gradually, and because of that, what happened, the HCG was at, because this ratio changed, because we all know that the menopausal women have higher FSH than the LH, and this to keep this ratio in the same range 1:1, we had to add HCG, or we are adding SCG to this more purified extract of derived from the human this postmenopausal women urine. We are adding more SCG to maintain this ratio of bioactivity, that is 1:1. So this is achieved not by adding LH but adding SCG, because SCG and LH can be used interchangeably. So this is the combination of both FSH and LH, this human menopausal gonadotropin known as menotropins. ठीक है. Now अब हमारे पास है follicular stimulating hormone also. We can with the advent of new technique and all that, earlier this follicle stimulating hormone was also extracted from the urine of the menopausal women, which is known as urofolitropin or purified FSH or UFSH also. So this purified preparation, though usually have a little bit of LH, but by using a technique called immunoaffinity chromatography. We virtually removed all traces, even the traces of the LH, and it is a purified preparation of FSH, that is derived from urine. So it was achieved by adding anti-HCG antibodies, not against LH, because structure is same. So if we have anti-HCG antibody, that will neutralize the LH as well. So so these are the purified urinary FSH or urofolitropin. We have recombinant FSH also. So there are two types of recombinant FSH, that is folitropin alpha and folitropin beta. So how do they differ from each other, this folitropin alpha and folitropin beta? This folitropin alpha and folitropin beta and have similar amino acid sequence as the native FSH, human FSH, but this folitropin alpha, folitropin beta and urofolitropin, that is purified FSH, they all differ from each other in the composition of the carbohydrate side chain that is attached to them. They differ in that actually. Otherwise, this recombinant one actually has the same amino acid sequence as and which is extracted from the urine also will have same, because that is from ultimately being extracted from the urine. The problem with the recombinant FSH is that it has a shorter half-life if compared to its purified extract that is derived from urine, UFSH, urofolitropin. But it is capable of stimulating estrogen release as efficiently as UFSH can do. So it is have similar efficacy or similar efficiency in releasing estrogen as well. But these recombinant hormones have other advantages, offer other benefits over this purified urinary FSH, that is in terms of, because they have much lower protein contamination, and they are have less batch to batch variability in activity, and moreover they are less likely to cause local tissue reactions in comparison to urinary FSH. But they are expensive because they are recombinant products. So in comparison to this purified FSH, that is urofolitropin, and this recombinant FSH, folitropin alpha and beta, are more expensive. And these gonadotropins requires, I told you that their half-life varies from 10 hours to 40 hours depending upon the preparation or the route of administration you are adopting. So they need to be given every day through injection. A new product, a designer molecule was created, that is called chorefolitropin alpha. Why it is chorefolitropin? Because it is little mixture of folitropin plus chorionic gonadotropin. So you can see why it is called chorefolitropin alpha. You can see it is a similar FSH molecule which has same alpha unit of FSH, same beta unit of FSH also. But to this beta subunit FSH, we have attached the C-terminal peptide of beta subunit of SCG. This change we have done, and because of this change, this particular formulation or particular drug could actually act longer. Its duration of action increased, its half-life increased, and this is also a very powerful and consistent stimulant of follicular stimulant. But the advantage is that it can be given once weekly. So during a IVF cycle, you can give it once, one injection, and that would obviate the need of the 7 injection of the FSH, and that is why it is approved for the use in this controlled ovarian controlled ovarian stimulation. This is with this GnRH receptor antagonist. Okay, so this is choreophyltropin alpha. That is the advantage, that it acts longer. Fine. Luteinizing hormone, we have only lutropin, because in urine, postmenopausal women and all that, the urine is not rich in LH. So we have lutropin alpha, that is the first and the only recombinant form of human LH, and it has been approved only to be used with folitropin alpha, and that to stimulate follicular growth only in those women who are infertile, only in infertile hypogonadic, hypogonadotropic hypogonadal females who have profound deficiency of LH. Profound deficiency of LH, because they are hypogonadotropic hypogonadal, because there is defect at the top. So they are very, pituitary or thalamus may be at fault. So LH level is very low. So we are using with folitropin alpha. Folitropin alpha will act as FSH. This is FSH, and we are adding this recombinant lutropin luteinizing hormone. The follicular growth in hypogonadotropic hypogonadal women, infertile women, right? And the advantage with this choreophyltropin also is that it actually act only as FSH. It does not have any intrinsic or inherent LH or HCG like activity. No intrinsic LH or HCG like activity. So one might anticipate that when some part of HCG is attached to it, it might have or cross react with LH receptors also. No, it is purely FSH, act as FSH, right? So this folitropin with lutropin, would be required in women who require controlled ovarian stimulation, but those who are hypogonadotropic hypogonadal, they may require this addition of LH lutropin also with folitropin, because otherwise there will not be proper development of the follicular. And also it is to be used in condition when we use instead of GnRH analog, if we use GnRH receptor antagonists, because they are causing more complete suppression of LH. So for that reason we may have to use LH, same thing. LH, we have to combine LH with FSH to ensure proper follicular development, because for development both the things are actually required, both the gonadotropins are required. This lutropin has also benefited some normogonadotropic women, those who have failed to this folitropin alpha therapy, earlier folitropin alpha monotherapy. So if lutropin is added to that, some women with normogonadotropic hypogonadism may benefit actually. But other than this, in controlled ovarian stimulation, the lutropin is not approved to be used with other than folitropin alpha with any compound, and not for any other indication like ovulation induction or something. It is not, because LH surge is required for, so one is not advised to use it for LH, ovulation induction and all that. Its only use is in IVF or this controlled ovarian stimulation in women with hypogonadotropic hypogonadism, when they have extreme deficiency of LH. So then it is to be used in combination with folitropin alpha. Otherwise folitropin alpha is sufficient, and this basal LH level in women is if sufficient, that would lead to normal follicular development. It is not needed then. Human chorionic gonadotropin, as I said, this is a placental hormone, and it is derived from the urine of a pregnant woman. Other things were all derived from or obtained and extracted and purified from the postmenopausal women. But here the pregnant woman, because it is produced from the placenta, is syncytiotrophoblasts, because it has a physiological role to play, because it maintains corpus luteum up to the 8 weeks of pregnancy. Once human maternal LH is not capable of because that with increasing estrogen progesterone concentration, the LH level goes down, so that is not capable of maintaining the pregnancy. So HCG takes the charge of the maternal LH. we have recombinant form of human chorionic gonadotropin, and that is known as choriogonadotropin alpha. This choriogonadotropin alpha has more consistent biological activity. More consistent biological activity in comparison to any gonadotropin, right? So that is why this drug, this recombinant form of human chorionic gonadotropin is packaged and also dosed on the weight basis, not on unit basis. So it is available as 0.25 milligram or 250 microgram in 0.5 ml. They are pre-filled syringes, I think, available with that, and maximum dose permitted is only 250 microgram, should not be more than that, or 0.25 milligram, that is equal to 0.25 milligram. So this is this is dosed on the weight basis, not on, and can be given as intramuscular or subcutaneous injection. So just remember this. Otherwise, all gonadotropins are given on the unit basis. Just because this has most consistent biological activity. This is the reason why it is dosed on weight basis, not unit basis. What are the clinical uses of these gonadotropins? We have discussed about gonadotropins and all that. We know that these LH and FSH have complex effects on the reproductive tissues, in both sexes, both in male and females. Especially in females, actually, what happens? This complex effects keeps changing over the time duration or time course of the menstrual cycle, and that results from the a complex interplay amongst the concentration dependent effect of this gonadotropins, concentration dependent effects of the gonadotropin on the tissues, as well as crosstalk between LH to FSH, and these gonadal steroids, etc., and also the effect of other ovarian hormones. So there is a complex interplay amongst all these factors: gonadotropins, concentrations, the concentration dependent effects of these gonadotropins, crosstalk between the LH, FSH and gonadal steroids, and the influence of other ovarian hormones, etc. So this is a little complex, and it keeps changing during the entire, with the time course of the menstrual cycle. So this is not fixed, this keeps changing. So this a very well balanced activity is required for successful menstrual cycle and attainment of pregnancy, etc., or continuation of the pregnancy, etc. So most common use of these gonadotropin is the ovulation induction, especially in those who are anovulatory, and because of that they are infertile, and that could be related to or secondary to hypogonadotropic. Hypogonadism means there is a defect in either the pituitary or at the hypothalamus level, or the women with PCOS, polycystic ovarian syndrome, or women who have more extreme obesity, etc. That also induces insulin resistance, etc., and that could produce a picture like PCOS, etc., and maybe any other cause. So in these cases, ovulation induction is achieved by these gonadotropins. In fact, this gonadotropin treatment is very expensive, as well as it requires close monitoring during the treatment in the form of repeated estradiol level, as well as the size of the follicles through repeated ultrasound, etc. So that is why it is always prudent to use some less complicated regimens of therapy before trying these agents. So these are reserved for only those women who failed to such less expensive, less complicated ovulation induction therapy or regimens. So one such regimen is the use of clomiphene citrate. You must be knowing this clomiphene citrate. This is an ovulation inducing drug, clomiphene citrate. It acts very nicely. If you see what happens, on pituitary there are receptors for gonadotropin receptors. So this estrogen and progesterone acts here or hypothalamus. They can, as I said, they have both action, negative positive feedback action or negative feedback action. Now we'll talk about the negative feedback action. That is different thing. Positive feedback occurs during the time of ovulation, etc. So what happens, this clomiphene citrate is a partial agonist at these receptors, partial agonist, and normal full agonist for this receptor is estradiol, which is produced naturally circulating in the human blood or females. So this actually, in presence of partial agonist, the full agonist cannot act, because in presence of full agonist, this partial agonist, this clomiphene citrate will act as an antagonist. So what will happen? The pituitary and the hypothalamus will sense it as there is deficiency of estradiol. So they will start producing more and more gonadotropins, LH and FSH. So they secrete more LH and FSH, and there may be massive release of LH and FSH, and may induce, this clomiphene citrate may induce ovulation in because of this massive release of LH and FSH, and is successful in many cases. So this is how this very well planned strategy, these partial agonist molecule, how wonderfully this, how nicely it is affecting the whole physiology, and forcing pituitary to release enough LH and surge and all that can produce ovulation. So we can try clomiphene citrate 50 milligram for 5 days orally, and this is available orally also. If ovulation does not occur, we can repeat the doses within 30 days, next 30 days, same for 5 days. And some women may require even 100 milligram. We can try, if lower doses are not successful, we can try higher doses like 100 milligram. But the diagnosis should be reassessed if there is after 3 cycle of use of this the ovulation does not occur, or if ovulation occurs but women fail to continue or produce, or it fails to produce, or women menstruation does not occur even after ovulation and all that. So one should reassess the diagnosis. There could be something else which we are not in fact aware of. Another use of gonadotropins I have already discussed. They are most commonly used for the same thing. This is only just ovulation induction. This you are actually doing for IVF actually, but you are doing the same thing, ovulation induction. But so controlled ovarian stimulation in assisted reproductive technology, that is IVF cycle, in vitro fertilization cycle. The side effects that these drugs can produce is most common ones are multiple pregnancies and important. Actually, why I am talking about these two, because these are important. There are many, but these are important side effects. This is ovarian hyperstimulation syndrome, OHSS. This could be sometimes life-threatening even, and multiple pregnancy is also considered as a high-risk pregnancy. Suppose triplet or quadruplet pregnancy occurs, then this could be a risk to a mother's life also. It's not easy. Multiple pregnancy is always considered as high-risk pregnancy. So these are the important side effects of use of these GTs in controlled ovarian stimulation and all that. And in case of male infertility, etc., what we can do, we can always induce signs and symptoms of pubertal changes just by giving exogenous androgen, that is testosterone, and this can achieve this can take care of your delayed puberty, development of sexual characteristics, male pattern hair, mustaches and beard, etc., everything, pubic hairs, etc., that can be developed by this exogenous testosterone. So obviously this sexual development can be achieved with exogenous androgen, but to have family, to produce a child, the man should have proper spermatogenesis, and for spermatogenesis that cannot be induced by testosterone alone. For that we need gonadotropins, because these are required. So it is a general practice that induce all these sexual developments etc. with exogenous androgen, that is testosterone. And whenever it is required, fertility is required, means a man wants to have family, then in that case we start treatment with the gonadotropins. Because what happens, first of all, this gonadotropin treatment, if you start right from the beginning, is very costly. That is one prohibitory aspect. Another is, in rare cases, the gonadotropin resistance may develop, and they will be no longer acting because of the development of neutralizing antibodies in some against LH and FSH. So that is why this therapy is reserved only when fertility is required. So whenever a man wants to have family and the proper spermatogenesis is achieved by use of these gonadotropins use, and for which we use human chorionic gonadotropin initially in the doses of this, you can see 1500 to 2000 international unit IM to subcutaneously, and thrice week until full steroidogenesis occurs. And this is confirmed by clinical examination and all that, and the serum testosterone concentration to see whether the full induction has occurred or not. So serum testosterone levels are within the normal range or not, right? If that is achieved, we can decrease the dose to this 2000 international unit twice, or 1000 international units thrice a week, means we have reduced doses to almost cut down to 30-40%. Not means cut down by 30-40% almost. But in some individuals, they fail to develop adequate spermatogenesis with HCG alone, so they might require treatment with recombinant human FSH, and that needs to be added along with HCG in the dose of 75 to 150 international unit thrice a week, so that both the with the help of FSH and HCG, the pre-pubertal testis gets matured, and it might take more than 6 months, and optimal spermatogenesis may take even longer. Sometimes it may be up to 2 years may be required for a man to achieve normal spermatogenesis etc. And this is but one good thing is that when natural or normal spermatogenesis is initiated or resumed, one can continue with only SCG regimen to have successful spermatogenesis throughout his life, as long as they want, without the need of FSH. This is one good thing. You don't need FSH anymore. Cryptorchidism is another indication for use of these gonadotropins. For example, cryptorchidism is defined as undescended unilateral or bilateral undescended testis, means the testis fail to reach to the scrotal sex unilaterally or bilaterally, both, and this cryptorchid testis is have defective spermatogenesis, as well as they are more prone to undergo cancerous changes, that is germ cells tumors. And these undescended testis needs to be reposed as early as possible, most typically around 1 year of age, or definitely not later than 2 years of age, definitely before 2 years of age. So it is believed that by increasing the local action of androgen, the testicular descent may be enhanced or can be promoted, and this is the reason or the rationale behind using this gonadotropin therapy in cryptorchidism. So for this, HCG is given in 6 doses, that is anticipating that this HCG will induce testicular descent, and dose is usually 300 international unit per meter square of body surface area intramuscularly every other day. for 6 doses. This is the typical regimen for inducing this androdescendant. But when this fails, then one has to go definitely for orthopexy, and chances of failure are much higher because the efficacy of this HCG therapy is much lower, that is around 20% only. They are successful, this treatment is successful, but the orthopexy can achieve more than 95% success rate. So this surgical manipulation or reposition is more favored, and many of the surgeons do not even prefer therapy with HCG even if it has 20% success rate, because there is a risk of developing germ cell apoptosis. So this germ cell apoptosis will even if the testis is in the scrotal sac, but when these germ cells are damaged, the chances of infertility is higher. So many surgeons do not prefer this medical therapy, etc. They directly go for orthopexy. Gonadotropin, other than therapeutic uses, also have diagnostic uses. For example, pregnancy testing. These kits are available quite easily over the counter because you need not have any prescription for buying them, and they are available with several names, Prega News and all that in India. And this kits actually contains antibodies against the unique beta subunit of HCG, because we know that in all gonadotropins these beta subunits are different, that and though HCG binds with the LH receptor, but there is a difference in the beta subunit, but that of LH and FSH in glycosylation residues. So these antibodies are against these beta subunits of HCG, so one can easily diagnose pregnancy. And this is a qualitative test. This will just give you an idea, yes or no. So this just after the few days of missed period, this pregnancy can be confirmed, because the increased secretion of, there is increased elimination of beta HCG, because that is as it is being produced by the placenta. So in pregnant women's urine, that the concentration is high, so because the antibodies are present in this kit against the HCG, so that will lead to definitely reactive reaction will occur, and that will give you a result within few minutes or few seconds that pregnancy is there or not. Not only that, there are quantitative measurement also. This was the qualitative test, that the result is either yes or no, but quantitative measurement, what are the serum level of HCG, that is actually measured by this immunoreactive method, that is called radioimmunoassay. This is also an immunological assay. So it is actually done to confirm whether the pregnancy is proceeding normally or not. Actually, with in advancing pregnancy, the level of HCG will increase. So that will give an idea, yes, pregnancy is proceeding normally. And just to detect the other complicated problems that can arise during the pregnancy, that is ectopic pregnancy that has implanted the embryo, which has implanted in the uterine tube, etc., elsewhere other than the uterine cavity. So in such cases, there is very high level of HCG can be detected. Hydatidform mole, choriocarcinoma, these are all things which are related to serum HCG level changes. And also they are serum concentration of HCG is measured for supervising the therapeutic response or adequacy of check the adequacy of therapeutic response of therapy that has been employed for the treatment of germ cell tumors, because germ cell tumors secrete HCG. So this HCG level, if that comes down, it means the patient is responding to the prescribed therapy. The measurement of these gonadotropins, for example, LH can also be, can tell you the timing about the ovulation. So usually after the onset of endogenous LH surge, it takes around 36 hours for the ovulation to occur. And if that is the best time, if sexual intercourse is done at that time, the chances of pregnancies are highest. And thus this can optimize the achieving a normal higher pregnancy rate. So usually this is achieved by, just to know the timing of ovulation, the urinary LH levels are measured every 12 to 24 hours, every 12 to 24 hours. from 10th day of the menstrual cycle, and considering the cycle is of 28 days. Regular cycles are there, otherwise it may vary from person to person. So that will give you an idea when the LH surge has occurred, and the ovulation occurs almost 36 hours after that. So this opportunity or this kind of information can always facilitate identification of the time of ovulation and can increase the chances of pregnancy. Also, for localizing endocrine disease, where exactly the lesion is, for example, we measure LH and FSH level with beta subunit as specific radioimmunoassay, because beta subunit is different for LH and FSH, so antibodies are made against these beta subunits. So this can actually identify or localize the defect. For example, if the levels are low, depending upon the signal generated by this immunoreactive activity that is detected by radioimmunoassay, if it is low, that will give you an idea that the defect is or deficiency of this LH and FSH is because of the hypogonadotropic hypogonadism. But this will not tell you whether it is due to the hypothalamus or pituitary hypothalamic or pituitary defect, but it is definitely the higher defect. Or the primary gonadal disease, when there is high level, because when gonads are not able to produce the testosterone or estrogen, progesterone, what happens? There will be decreased negative feedback inhibition of the LH and FSH, and the LH FSH levels will be very high in the plasma. So this indicates or points to the peripheral disease, primarily related to gonads, the target organs. So this can be used for localization of the lesion, endocrine lesion. These gonadotropins are also used for assessing the lady's cell functions in males, especially those who are having delayed puberty and etc. So this can be identified by you give multiple injection of SCG and measure the serum testosterone levels. Even after multiple injection of SCG, which acts as LH, and LH is important for stimulating the testosterone production from Leydig cell. So if the response is diminished, though there is no satisfactory increase in testosterone level, it indicates that defect is in the Leydig cell. There is Leydig cell failure. Or if the response is normal, then the defect is there in the hypothalamus or pituitary level. So this is also a kind of lesion, where exactly lesion is lying, where is the problem, whether it is a gonadal failure or the much higher defect. So we were talking about adverse effect of GTs. With there, I told you that controlled ovarian stimulation, the important one is OHSS, that is ovarian hyperstimulation syndrome, that merits discussion here actually. Usually as such also, if you stimulate ovaries with the gonadotropins, which we usually do during the in vitro fertilization cycle, the ovaries often enlarge, but that is without any complication, and that enlargement regresses over a few days. And in some there may be OHSS that can present as for example, that can present as ascites or liver function dysfunction, liver function impairment, or it can be pulmonary edema, or it can produce thromboembolic events, electrolyte imbalance. So this in fact also is self-limiting, usually disappears within days. But if not, and if it is in the severe form, that it may be very dangerous, also life-threatening also. The patient may require intensive care unit, may need to be put under intensive care, and proper care needs to be taken to avoid any sinister result. So we consider that it is believed that the injection of SCG, which is given for this inducing of for final maturation of oocyte, that is that induces actually LH surge, because we artificially induce LH surge. We prevent endogenous LH surge by giving certain drugs that I will tell you. So this is responsible for risk of inducing OHSS. So the alternative for that is you use either GnRH agonist in terms other than this SCG. What happens, this GnRH agonist can be used as an alternative to SCG, and this GnRH agonist will produce LH surge, and the advantage of this GnRH induced LH surge is that the duration of that LH surge is smaller, and that could be definitely associated with lower risk of inducing OHSS. This is the explanation or logic behind using GnRH agonist in place of HCG injection, right? In males, the most common side effect of this important side effects, common can't say, most important side effect is gynecomastia, and up to 1/3 of the patient, that is every third patient treated with these gonadotropins for infertility etc. can develop gynecomastia, and this is probably due to the induction of aromatases by this gonadotropins. So there is increased synthesis of estrogen in the periphery etc., and that is responsible for gynecomastia, this particular side effects in the males. Okay, so this was all about gonadotropins. We have covered gonadotropins. Now we will be talking about prolactin, which is another hormone from anterior pituitary. Posterior pituitary hormone we have already discussed during this AVP. We have already discussed in diuretics and antidiuretics hormone, antidiuretics agent, and this oxytocin we will discuss when we talk about the drugs active on uterus and all that. So this prolactin, you can see it is actually released under the influence of thyrotropin releasing hormone, which is also a stimulating or trophic releasing factor for hypothalamic releasing factor for TSH, which actually maintains thyroid. And dopamine has prominent inhibitory effect on prolactin release. Earlier we were not aware that there is also a stimulatory factor. We always thought that prolactin is only under the inhibitory control, but this is actually not true. The TRH can enhance release of prolactin, but when this prolactin is increased, there is hyperprolactinemia in the blood because any reason that we will be discussing right now, that can actually inhibit GnRH release from the pituitary hypothalamus, and that will lead to reduced LH and FSH, and that can actually lead to the problem of infertility etc. with prolactin. Got my point? Because that indirectly affects GnRH as well. So this prolactin is important. Target organs are breast, mainly milk synthesis and all that, but it can also act on other tissues, especially the reproductive tissues and all. There could be two kind of problems associated with prolactin. That is, either there may be deficiency, so this may manifest as the deficiency of prolactin, either failure to lactate just after the the female gives birth to a baby, the female failed to lactate, or it can lead to, if that is not the case, there may be luteal phase defect in deficiency, or that is why these females are usually infertile because of deficiency also. And very surprisingly, we have almost every hormone which can be used as a replacement when there is a deficiency, but prolactin does not have such product or formulation available with us. Hyperprolactinemia, that is raised level, can occur in certain situations. So for example, where there is damage to the pituitary stalk. Pituitary stalk is a connection between the hypothalamus to the pituitary gland proper. This is stalk. It is hanging from the hypothalamus with the help of a small stem kind of thing. So if it is cut during the surgery, or maybe damaged due to the head trauma etc., or there could be a compression of this pituitary stalk by the cellular mass, so that can inhibit blood flow etc., any movement from flow of any substance from the hypothalamus to pituitary, or in rare case there may be hypothalamic destruction, because for all hormones the releasing factors is released from the hypothalamus. So and because this hypothalamus is release of prolactin is predominantly under inhibitory control. So because of this pituitary stalk lesion or hypothalamic damage, there will be no sufficient dopamine which can inhibit the release of prolactins, and that will lead to hyperprolactinemia. But other than this theory that damage to the pituitary stalk or hypothalamic destruction, more common causes of hyperprolactinemia is the prolactinomas. These are the adenomas related to lectotropes of the pituitary, and they could be microadenomas, macroadenomas, and these are actually the more common cause of increased serum prolactin levels. In certain cases, this hyperprolactinemia may be related to or secondary to use of certain group of drugs, especially these antipsychotics, neuroleptic drugs, because they usually act as dopamine receptor antagonist due to receptor antagonist. So they can inhibit this inhibitory control on the release of prokinetic agent. This prokinetic agent also have antidopaminergic effect like metoclopramide, etc. Estrogens, opiates, this opiate compounds, and also this clinical condition like primary hypothyroidism. We told you that primary hypothyroidism is there, means defect is in the gland itself, thyroid gland. So it is not able to produce thyroid hormone, either maybe deficiency of the iodine or maybe some disease of the gland. So that will actually reduce negative feedback action on the pituitary and thalamus. So that will lead to more TSH release, more TRH release. So TRH is a positive or stimulator of the prolactin release. So that can lead to hyperprolactinemia. So primary hypothyroidism. So that is why patient who have or come with complaint of infertility and all that, this thyroid function assessment is also important, because this may indirectly related to this prolactinemia, hyperprolactinemia, etc. So hyperprolactinemia can cause hypogonadism, features of which may vary in females and males. In females, it is mainly associated with oligomenorrhea, amenorrhea, or it can cause even galactorrhea or infertility. In males, it can cause infertility is one thing, but it can also affect erectile dysfunction. It can cause loss of libido, etc. So they are all associated with infertility and hypogonadism. That is why I have already told you that increased serum prolactin level can indirectly inhibit the GnRH release from the hypothalamus, so ultimately leading to decreased gonadotropin release and reduced gonadal hormones. When a patient turns up with symptomatic hyperprolactinemia, then the treatment of choice is the dopamine agonists that are available with us, because this dopamine can effectively inhibit the release of prolactin, because they have this dopamine has inhibitory control on the prolactin release. So we are not using dopamine, we are stimulating dopamine receptors in the hypothalamus or in the pituitary. And one good thing is that despite development of these adenomas and all that, these prolactin secreting cells retain sensitivity to they are equally sensitive to inhibition by the dopamine. This control or this regulation is not lost. So this is very important thing. That is why these dopamine agonists are so effective in the treatment of hyperprolactinemic state and all that. So several of dopamine agonist such agents are available, and we have ergot derivative and non-ergot derivatives. For example, this bromocriptine, bromocriptine and cabergoline, they are dopamine receptor agonists, and they bind with high affinity to dopamine 2 receptor, as well as this quinagolide, which is non-ergot derivative. These two are ergot derivative. Ergot derivatives have some alpha 1 receptor agonistic activity, partial agonistic also there. So this non-ergot, this is more commonly used in Europe, and this has also similar affinity to D2 receptors, binding antagonist of D2 receptors, agonist of D2 receptors. and they all can suppress prolactin release very effectively, and can bring down the prolactin levels to the normal serum, can correct serum. And in case of acromegaly, in fact, these agonists can also reduce the release of growth hormone also, but not as effectively as the suppression of the prolactin release. So many a time these dopamine agonists are used in acromegaly in combination with other therapy. So this cabergoline is an ergot, has first of all, these all agents can be used orally, and even cabergoline is available as a vaginal tablet also. So this cabergoline is all are orally available and gets metabolized also, undergo metabolism. This cabergoline has the longest duration of action. You can consider that its half-life, you can see, is around 65 hours. Among all, this is having the longest duration of action. And quinagolide has 20 hours and bromocriptine 7 hours. But there are other preparations of bromocriptine which are longer acting also available in different countries. And other dopamine agonists that are used for the treatment of Parkinsonism, that are non-ergot derivative, that is pramipexole and ropinirole. These two are non-ergot dopamine receptor agonists which are used in Parkinsonism. In fact, bromocriptine is also approved for use in the Parkinsonism. These two agents have shown effect, in fact, on the lactation, control of lactation and all that occurring in the case of hyperprolactinemia, but they have not been yet approved for treatment of hyperprolactinemia. So only we have these three agents available with us, and cabergoline, when it is administered as vaginal tablet, the plasma rise in the concentration is little slow. That is the only difference, but it does not make any difference because we do not need any quick effect or something like that. It is a condition where you don't need to have abrupt effect or something like that. So dopamine agonist, as I said, are considered as first line treatment for this hyperprolactinemia, and they not only shrink tumor, decrease the size of they also appreciably lower serum levels towards the normal, in fact, and can even restore ovulation. It can restore ovulation by 70% in those who have microadenoma, and 30% up to 30% those who have macroadenoma. This micro and macroadenoma is depending upon the size, So treatment is usually started with cabergoline, that is needs to be given 0.25 milligram twice weekly. Because of its long half, it is possible to give it twice in a week, either orally or vaginally. Both the routes are available. And bromocriptine is to be given once daily after dinner. This is a long acting preparation, and it can be given in a dose of 1.25 to 2.5 milligram at the time of bedtime. And the reason being daily after dinner, because it is associated with a lot of nausea and all that, so that would be curtailed. And at night time, because you will be going in sleep, and also it has orthostatic hypotension and all that is the common side effect of this drug, so that can also be reduced. So we keep increasing the dose as necessary. For example, cabergoline is usually used 0.25 milligram twice weekly, and we gradually increase by every time 0.25 milligram, and that too after every 4 weeks. And the maximum dose we can give is 1 milligram twice weekly, not more than that. And bromocriptine, the patient usually settles on 2.5 to 15 milligram. But some patient may require 30 milligram of the doses per day, especially those who are having either amenorrhea and or galactorrhea. On those patients, you may have to employ higher doses, maybe up to 30 milligram. Otherwise, most of the patient respond to up to 15 milligram of doses. And of course, the drugs, the doses is to be increased in the as every time by 2.5 milligram in case of bromocriptine, 0.25 milligram in case of cabergoline, 2.5 milligram in case of bromocriptine, but here more frequently, that's every 2 to 7 days. You can change every weekly. You remember it, every week, and this every 4 week. And quinavolide is given once daily at doses of 0.1 to 0.5 milligram. Right. So there is also a lot of variation from 0.1 to 0.5 milligram, 5 times almost. I told you that these dopamine agonists are also capable of reducing growth hormone production from the somatotropes, pituitary somatotropes. So these agents are also good or sometimes employed in the treatment of either alone or in combination with surgery or radiotherapy or with somatostatin analog like octreotide, etc. But the doses which are required in acromegalies are much higher than that is what is required in case of this prolactinoma or hyperprolactinemia. And you can see the bromocriptine doses may be required up to 220 to 30 milligram per day, but in that case in hyperprolactinemia it was 2.5 to 15 milligram. So here the doses are on the higher side. And sometimes the bromocriptine can also be used for suppression of lactation in case the baby delivered is dead or something, and mother the suppression of lactation is must to prevent breast engorgement and infection. So in that case people used bromocriptine, but it is not recommended now because of the side effects associated with the use of bromocriptine. The common side effects that have been reported with the use of these dopamine agonists is nausea is very common, because we know dopamine receptors are present there on the CTZ chemoreceptor trigger zone, which is outside the blood-brain barrier as well as in the vomiting center, etc. So nausea is very common, and occasional vomiting also can occur. And that was the reason that it is to be given at bedtime. Headache, orthostatic hypotension, because dopamine can cause stimulation of dopamine receptor can cause vasodilatation and all that. Psychiatric manifestations, though they can occur even at lower doses. It's not necessary that it requires higher doses. It can occur even at lower doses and may take even months to resolve even. Because the idea behind treatment of psychotic episodes with anti-dopaminergic drug is that there is hyperstimulation of dopamine receptor. There is dopaminergic therapy behind psychosis and schizophrenia. So here we are stimulating dopamine receptors, so we are creating picture like psychiatric, this psychotic symptoms. So these psychotic symptoms may develop and may take several months to resolve, and they can make their appearance even at lower doses. Erythromelalgia is a very rare condition, and that occurs rarely with the use of these drugs. As the name suggests, erythromelalgia, there is severe burning, that is pain in the foot and sometimes in the hand also. It affects mainly extremities. The hands becomes red or foot becomes red, and there is increased temperature as well. So this erythromelalgia, so it may occur in the episodic form, or it may be even sometimes very continuous. So this is really may require discontinuation of the treatment. And if high dosage ER used for prolonged period, it may result in peripheral cold-induced digital vasospasm. Moreover, because this these ergot derivatives like cabergoline and bromocriptine, they usually have agonistic action, partial agonistic action at alpha-1 receptor. That is why this is there is higher chances of this peripheral digital vasospasm, if more common during the cold and all that. Pulmonary infiltrates, this is also an important observation with ergot derivatives, and this picture is same. You can see this, these all these are infiltrate. Cabergoline is causes nausea with frequency of nausea associated with cabergoline use is much lower than the dopamine, and this can be further reduced by vaginal administration, but it can cause local irritation and all that. Local problems can be there with the vaginal administration. But the good thing is that the treatment may even be continued during the pregnancy if luckily the mother, the female become pregnant. the treatment may be continued during the pregnancy, and the outcome of the pregnancy may be very good, in fact. So this is the IVF cycle. I told you I will tell you about this assisted reproduction technology, in vitro fertilization, how we achieve this. It is actually, this cycle is fully under the control of the treating physician. He or she knows when and what is to be done, and which therapy is to be used, and all that. So we usually start, once this menses starts, from the very second day of the menses, we start giving gonadotropins. So this is for follicular development, because this is the follicular phase. You can see this is showing the follicular phase. Just after the menses, follicular phase starts. So what do we use for follicular phase? Do you know that we use polytropin alpha? But I told you that with certain infertile hypogonadal women, they may not have they have extreme deficiency of this LH, basal LH level, so the proper follicular development may not occur. So you have to add I told you lutropin alpha, that is LH, and this is the only indication for lutropin alpha with polytropin alpha added. So, and also I was telling you that when we use GnRH antagonist, that is that these agents cause more effective suppression of LH. So that may also interfere with the proper development of the follicles and all that. So in this condition, you may require this combination, polytropin alpha with lutropin alpha. And you see this gonadotropin is being given, and during this time you keep measuring the serum estradiol level, and also you do repeated ultrasonography to measure the diameter of the follicle, whether it has been matured or not. Once you have decided it has reached to a particular, as per your requirement, you achieve final induce LH surge and induce further oocyte maturation with the injection of the HCG at this point. And this is said that it is to be done when two follicles at least 18 millimeter in size are actually observed on the ultrasound. And these gonadotropins are given for the development as well as of the follicles, but these agents are given to prevent premature LH surge, which can occur with your endogenous LH surge, which can vitiate the entire program. So once it is done, then after maturation the oocyte is retrieved from the this ovary, and it is the in vitro fertilization is achieved outside the body, and that it is transferred, this embryo is transferred in the recipient, and the pregnancy is maintained with the outside progesterone, etc. Because that has to be supported from the outside administration of progesterone, because there is no corpus luteum, etc., because everything is achieved outside. And to prevent this endogenous surge, so during luteal phase, if we see from the preceding, we are starting from the menses second days here, but preceding part of the luteal phase, we start giving GnRH agonist to prevent endogenous LH surge. Reason being, this is longer. You can see it is very long. The time required is long. It is to be given for many days. But GnRH antagonists, this is cetrorelix and genirelix, they are required for some less time. They can be given only during the follicular phase. So that is why I said their use can be delayed by 6 to 8 days, and they can thus reduce the requirement of the gonadotropin, decrease the dose and duration of the gonadotropin. But with this, you may have to add lutropin if you are using GnRH agonist, because of the more effective suppression of the LH. So the GnRHs are given for longer time. Why? Because for the first 7 to 10 days, they can have agonistic action. They can increase LH and FSH secretion by the pituitary. but with the time this GnRH receptor undergo down regulation, and then they start acting as the antagonist of the GnRH. There will be no further release of GnRH because there is no release of the gonadotropins because of the continuous stimulation of these GnRH receptors by these agonists. There is no GIT gonadotropin release because GnRH needs to be secreted in pulsatile manner to achieve proper secretion of gonadotropins. So this is how a test tube baby is produced. So this is all about this in vitro fertilization cycle, which is achieved in IVF centers, etc. So this was all about the pituitary, and I told you this oxytocin, etc. that pituitary hormone 1 we have already discussed during diuretic and antidiuretic class, and this will be discussed in when we talk about the drugs that affect act on uterus. So with this the entire thing in the and corticosteroid, I told you that that will be covered because ACTH as such has no much use. We have already discussed that ACTH is used in this anti-epileptic drug and certain conditions, for example hypsarrhythmia or West syndrome, and once again I remind you guys, you have this Telegram app so that you can join this group, and as I told you that you can receive notifications about the class timetables and all that. So that is always good to have this information because you need to take out time for these classes if you are really interested in attending. Many times it happens that you are waiting for a particular class to happen, and if you have this information beforehand, then you can always watch that particular lesson. And you are many a time you like a particular educator too much, and your favorite educator is giving lecture on any topic, you are always happy to listen to that, then you can enjoy those lessons. I have already discussed the advantage of this NEET PG plus subscription based service, which is a premium service. That is why it is available at a cost, and it's the live classes, etc. I told you there is many opportunity. You have ample opportunity to interact with the educator in real time, and it is more interactive kind of sessions you can say that happens on this platform. Other than that, there are live poll and leaderboard facility which are important for you as well, for us as well, because whatever feedback you give, we work according to that. And the leaderboard not only gives assessment of information about your self assessment, but gives information to us as well, where the actually group is staggering or something. And this test material, as I told you, they are available in the form of series, test series, quizzes, and their analysis also. So you should do as many as possible. And this is live doubt clearing session is just like cherry on the cake. So all these are the advantage of this Unacademy subscription. That is why this is available at a cost. And I would rather say you once join this and then feel the difference, because just watching from a distance will not give you any kind of so you have to get into the system to really enjoy the benefit of the such facility. You may be aware or not, I don't know, but there is an Unacademy learning app by downloading and installing this app will make you eligible for attending special classes. These classes are also absolutely free, and you don't have to pay a single penny for them. And the advantage with this special class is that its interface is such that will give you an idea about the Unacademy this plus subscription based service. And this gives you also opportunity to interact with educator in the form of chat box. Whatever message you write, whatever query you have, anything, you just write it in the chat box. It will be immediately visible to the educator, and the educator can always solve your queries and all that. And not only that, even if you have you are on this learning app, but you have query related to the same any other lecture taken by the same educator, you can ask query related to that also. Not during that class, but once you follow the educator on this app, you can send him direct message. So you can ask those queries by sending those messages, if those queries on this platform. So in fact, educator will be more than happy to revert back to you. So it's my suggestion, you just if you don't have this, download it and install it on your system and keep attending these special classes. I'm taking antibiotics on these on this platform, and tomorrow I will be taking aminoglycosides antibiotics. So those who are interested can join me over there. And on this, I'm continuing with these endocrinology drugs related to endocrinology, and plus I'm talking central nervous system. We have already covered anti-epileptics, the alcohol, the anti-anxiety drugs, hypnotic sedatives, and in the general actually introduction of CNS, that was important. So that has all have been covered on so but if you have plan to join this NEET PG, that is plus, then you have to go to on this app on the manage goals, under which you have to select NEET PG. Then you have under that category you have to select plus, and you have to click get subscription. And I have told you that though the subscription is available from 1 month to 24 months, but I always recommend, in fact everybody recommends, that you should go for these two, any one of these, depending upon the eligibility for which I said that those who are and UG students, they should go for this 24 months, because this is the cheapest and this will be the most beneficial subscription for them. And for post MBBS students, this much time at least they should devote with this plus to fully realize its potential, its benefits and everything. And don't forget to apply this code, the Dr. Pramod, which will not do much of wonders, but at least will get you 10% discount, and that is not a small amount. Anything saved is money saved is money created. So you will save at least 10%. That is not a small percentage of not a small percent. And you can pay by any mode of payment. Different digital modes are there, and you can pay by card or by UPI or anything. And those who subscribe for 6 months or higher duration program, then they become eligible for no cost EMI facility. So this actually becomes little more pocket friendly, because you don't have to pay a big sum upfront. So that is the advantage. So anyways guys, you keep enjoying this NEET PG live daily, and ask other friends to subscribe to it, and don't forget to click this bell icon, because you keep getting all the notifications. If you follow it, then you are getting everything free, and you really impressed with this lecture, and you really actually got some information, or good information in fact, and could understand the concepts behind pituitary hormones, etc. Then definitely like this lecture, and you can share the link of this same lecture with your friends also, and ask them to subscribe as well. So this is something which can you do for the educator. And last but not the least, again I am telling you to use my referral code whenever you have planned to join plus. This will get you 10% discount, and we also get some sort of appreciation from the Unacademy once a person joins using the code of particular educator. So that is also beneficial for us. So whenever you have planned, the subscription is open throughout the year. Whenever, anytime, you are welcome. And once join and then feel the difference. So this is all about Unacademy as well as the today's topic. With this, it's time to say or take your leave, guys, and I'm going to finish this class, and thanks for attending, and goodbye, good night.